Good afternoon. My name is Bruce Lambert from the Department of Communication Studies and the Center for Communication and Health at Northwestern University. And this afternoon I'd like to talk about this large question of why patients sometimes don't do what health professionals recommend that they do. People call this problem the problem of adherence or non-adherence. I'm actually not particularly fond of that term, and what I want to talk about today is an alternative way of thinking about this question about whether patients do as health professionals recommend that they do. So I want to ask, what would it be like if we took a patient-centered approach to this problem of adherence? And I think if we took a patient-centered approach, we wouldn't call it adherence anymore. We might use a term like self-regulation. That's the term that I'm going to use today. So I want to talk about, in 3 parts today, what it would be like to take a patient-centered view of this problem of adherence or self-regulation. It's really the question of why do patients sometimes choose, or do people who are sick sometimes choose not to do what professionals recommend that they do. I'm going to describe this work really like an editorial, which means I'm not going to provide a lot of evidence for everything that I say. I think there is a lot of evidence from research dating back to the 1970s for what I'm going to talk about, but I'm not going to go into that evidence in detail today. I want to instead invite you to think about this topic in a different way. And instead of thinking about adherence, I want you to think about the experience of illness. What is it like to be chronically sick? And I think if we can think about and empathize with the experience of illness from the chronically ill person's point of view, we can understand much better why people might decide sometimes not to do exactly what health professionals recommend that they do. I approach this problem from the point of view of a social scientist. I am a social scientist by training, and I make no apologies. I think a purely medical-centered analysis of this problem hasn't really gotten us very far. And so I think a different way of looking at it, maybe from a social scientific point of view, might allow us to make more progress. And probably in the end, we'll have some sort of integrated perspective, which integrates both a medical and a social scientific perspective on this problem. I learned about what I'm going to talk about today primarily from teaching. I've done some research about this and published some papers about this, but I learned about it mostly by teaching pharmacy students and communication students about the experience of chronic illness. And so it's interesting that I developed this perspective really through the scholarship of teaching rather than traditional research scholarship. And the conclusion that I come to is that we have the wrong implicit model of what sick people are like. That is, we tend to think about sickness being acute sickness like the common cold or the flu, when in fact the majority of the kind of sickness that people experience now is chronic illness. So I think we walk around with this acute care model or acute illness model of the experience of illness when what we need is a chronically ill model of what it's like to be sick. So the first point we begin with is a sort of very obvious point in health services research or in medicine, and that is that very, very frequently people don't do what doctors and nurses and pharmacists ask them to do. And this may be diet or exercise or drug therapy or self-diagnosis or even keeping appointments. People just don't do it, and they don't do it in very large numbers. The rates vary. It depends on what kind of behavior you're looking at. It can vary from maybe about 25% of the time people don't take their medication on average, to rates as high as 50% for more difficult regimens like self-diagnosis or diet or exercise. But we make all these recommendations. We tell people to diet, to exercise, to stop smoking, to moderate drinking, to take medications, to do self-monitoring. And people in very large numbers don't do it. So this is a very general finding across all sorts of illnesses and across all sorts of behaviors. And we're not really sure why. It's such a fundamental thing, and yet we don't completely understand it. If you were to do a search in PubMed, this bibliographic database of articles about health and medicine, I did it relatively recently. I found 74,000 articles about adherence. There's probably more if you were to search today. And in spite of these 74,000 articles about adherence, still 25% of the time people don't take their medicine, and up to 50% of the time people don't do these other behaviors. So all of this work hasn't led us to a solution that would help more people do what health professionals ask them to do and what we think is in their best interest. So this very high level and persistent problem of non-adherence, of people not doing exactly as they're told, it's really frustrating to health professionals. It makes them look bad. It makes them feel foolish. It makes them feel ineffective and irritated and frustrated and perplexed, or they just can't imagine why patients would take the time out to get diagnosed, often to undergo painful procedures and expensive tests. And then when you arrive at a diagnosis and come up with a treatment, patients go home and they don't do what we recommend that they do. On the surface, it seems bizarre, perplexing, even irrational. But I don't think it is. I think if we think about the problem from the patient's point of view, it's not irrational at all or bizarre. In general, health professionals think patients would be much better off if they would only do as they were told. This is the sort of the paternalistic legacy of medicine. But in general, health professionals, they're very well trained. They know the science. They do the diagnosis. They take time to develop a treatment plan, which is often based on good evidence. So we're convinced that people who are sick, these patients, would do better if they would do as we ask them to do. But they don't, and it leaves us in this confused state. So one of the ideas that's come along in the last 10 or 15 years is that maybe if we were patient-centered, this would help. But nobody knows exactly what it would mean to be patient-centered. We all sort of agree that being patient-centered would be a good idea, and maybe if we were more patient-centered, patients would be more likely to follow our recommendations. But it's not at all clear what it means to be patient-centered. So a lot of what I want to talk about today is, what would it mean to be patient-centered in the context of this problem of adherence? I don't think it means patient in the middle, with all of us looking at the patient through a biomedical kind of a lens. I don't think that's the answer. I think that's sort of what this is like. And I don't think that this is the answer, just feeling like you're being stared at and you're the focus of all this attention. Sure, you're in the center and you're the patient, but that's not what patient-centered was intended to mean. And I think this is how a lot of us feel when we find ourselves very sick, especially when we find ourselves in the hospital. We feel vulnerable and we're sort of the center of a lot of attention, but not in a way that necessarily makes us feel empowered or secure or happy or healthy. Instead, we often feel like this. We feel like we're in the bullseye somehow, that we're almost in danger. And from what we know about the safety and quality of medical care in the United States and around the world, we are in fact in danger when we're under treatment. So this isn't what we mean by patient-centered, to be in the bullseye. We must be able to do better than that. So maybe by patient-centered we mean through the patient's eyes. We'd like to see the world and understand the world from the point of view of the person who's actually suffering from the chronic illness. Something like this. But even this, isn't exactly right, because here the patient is about to undergo some sort of surgical procedure, and this is really not what it's like most of the time for chronically ill patients. I think nowadays we have these cameras that we can mount on our heads, or we can mount on our, the strap of our backpack and go around and videotape everything that we see. So if we imagine putting one of those, on the hat of a chronically ill person or on the strap of the backpack of a chronically ill person, and looking at the world from their point of view, we wouldn't normally see this. Most of the time, chronically ill people are at home or at work or out in the world. They're actually not in the clinic or the hospital very often. So I don't think this is it exactly, but it gives you the idea, at least, that we see the world through the patient's eyes. So in order to really do this, I think we need two kinds of understanding. And I say we need two kinds of understanding to help patients self-regulate more effectively. I prefer this term self-regulation to the term adherence. I think adherence has a lot of bad connotations. It hasn't served us particularly well as a concept. We saw these 74,000 articles which haven't shed sufficient light on this problem to help us solve it. I think a more patient-centered term is this term self-regulation, which means the patients are in charge. They have all sorts of symptoms, problems, fatigue, weakness, family problems, financial problems, sexual problems, relationship problems, legal problems, transportation problems. They have all the problems that come along with a complex chronic illness, and they're constantly trying to improvise solutions to these problems. So this process of constant improvisation, I refer to, and the literature refers to, as self-regulation. So instead of asking ourselves, what can we do to make sure patients follow our instructions? That's adherence. I think a more patient-centered question is, what can we do to help patients or help people who are chronically sick self-regulate more effectively, solve all these problems. I think if we look at the world through the eyes of people who are chronically sick, what we see is a world of many, many different problems, that solutions to these problems need to be improvised on a daily basis. So the question is, how do we help patients do that? It's a very different question from how do we help patients do as they're told or follow our instructions. So I think there's two kinds of understanding we need in order to help patients in this way. The first is an accurate ethnographic account of what it's like to be chronically ill. The ethnography means understanding, it's a term we borrow from anthropology. It means understanding a culture from the point of view of the members of that culture, or having an insider's view of an experience. So we want to understand chronic illness from the point of view of the people who are actually suffering from these chronic illnesses, and we'll call that an ethnographic point of view. So in order to help people solve these problems that they encounter, we need to understand in a very deep and detailed way what it's like to be chronically sick. Luckily, for about the last 50 years, at least since 1970 or so, there's been a growing literature that talks to chronically ill people, does long-form interviews with them, and learns about what the experience is actually like. And second, we need an accurate model of human navigation, motivation, cognition, choice, and decision-making. Sort of how do patients think in the context of their complex lives with chronic illness? I'm going to focus mostly today on the first of these questions, although I may talk a little bit about the second, especially about motivation. So first, this accurate ethnographic description of chronic illness. These are terms which are important to think about and to understand in the context of this sort of presentation. So the first is ethnography. I already introduced that. It's this anthropological term which means understanding a culture from the insider's point of view. There's a type of theory which supports this work called grounded theory, developed by Anselm Strauss and his colleagues who were sociologists. This is a way of doing this ethnographic research. It depends largely on qualitative interview-based research. It's autobiographical in the sense that we care very much about people's own life stories. And it's psychological, meaning we care about what people are thinking and what people are feeling. It's qualitative in the sense that words, people's own narratives, the transcripts of their interviews, the videotaped interviews with them and so on, are the primary data in this kind of work. So I want to argue that self-regulation, this kind of improvisation, is normal. And that adherence, this idea of sticking rigidly to someone else's instructions, is abnormal. I think even those of us who are healthy, there are very few behaviors which we rigidly stick to in the way that doctors and nurses and pharmacists would like us to stick to certain drug therapy regimens or exercise or self-monitoring regimens. It's just not normal. It's not natural to stick to these sorts of regimens. Even those of us who are healthy and trying to stick to a dietary regimen or an exercise regimen, it's difficult to do, and we normally can't do it. So when patients are unable to stick to these regimens, we really shouldn't be surprised. What's much more normal is this improvisation, this daily struggle to try to get it right, in the moment, to try to figure out solutions to the various problems that crop up. So when preparing this talk initially, I tried to find examples of where people in everyday life stick to some sort of rule or regimen with a very, very, very high percentage of adherence, fidelity. And I could find only two that were above 90%, and those were wearing your seatbelt and brushing your teeth. At least people claim that they brush, more than 90% of people claim to brush their teeth once a day, and greater than 90% of people in states that have seatbelt laws actually wear their seatbelts. And there are studies of this where we can actually take pictures of people as they drive by on the highway and find that out. But those are the two exceptions. I couldn't find any other behavior. And I couldn't find any other health behavior where people came anywhere close to this level of adherence. So it's abnormal. What's normal is this improvisation. So in understanding the lived experience of chronic illness, I've been tremendously influenced by these two books. This book by Juliet Corbin and Anselm Strauss. Juliet Corbin was a nurse and Anselm Strauss is a sociologist, and they wrote this book, Unending Work and Care, Managing Chronic Illness at Home, where the book is really the story of these couples, where at least one of the couple had a chronic illness, and they did these long-form interviews with these couples and transcribed them and developed a theoretical framework around those experiences. And Kathy Charmaz was a student of Juliet Corbin's, and she wrote this other book called Good Days and Bad Days, which continues the same kind of work. And both of these books influence my thinking tremendously, and a lot of what you'll hear in this talk is really derived from what I learned from Corbin and Strauss and Kathy Charmaz. So by trajectory, this is what we mean. This is a graphical trajectory of the course of a serious illness. I got these from Lynn and Adamson from a paper that Rand published. So on the vertical axis here, we have a functioning or quality of life. And on the horizontal axis, time. And in this case, this is a trajectory of cancer. So often it's characterized by a relatively long, stable period of functioning where you can hardly tell the person is sick, followed by a rapid deterioration which ends in death. So that's a cancer trajectory. So trajectory is this course of quality of life over time or functioning over time. This is another trajectory from the same paper, which looks at organ failure, something like heart or lung failure. So here you have a lower level of functioning to begin with, where you have the slow decline punctuated by dramatic worsenings, these acute episodes or exacerbations of the illness, where things get much worse quickly, but people recover. They recover to a lower level of functioning. They continue with the slow decline, and then there's another acute worsening. And finally, they experience an acute worsening, which they don't recover from, and they die. So this is a heart or lung failure trajectory. I'm just trying to give people an idea of what this notion of trajectory might mean metaphorically. So Corbin and Strauss, having interviewed all these couples where one of the couple was chronically ill, identified a set of characteristics of chronic illness. And I think some of these, in retrospect, are very obvious. But if I had asked you to list some characteristics of chronic illness, many of them you wouldn't have listed. So I think they're only obvious in retrospect, and great credit is due to Corbin and Strauss for drawing our attention to these obvious facts. One of the most obvious being that home is the central site of care for chronically ill people, not the clinic, not the hospital. So the first patient-centered thing we would recognize when we think about chronic illness is that care for chronically ill people takes place primarily in the home and in the workplace, not in a clinic setting or in a hospital setting or an emergency room. Second, that chronically ill people care primarily about quality of life and not quantity of life. It's not that they have no concern for quantity of life, but quality of life trumps quantity of life according to most of these interviews with chronically ill people. The chronic illness requires lifelong work. That's why they call the book Unending Work and Care. There's the work of your relationships, the work of your everyday housework, the work of your employment, and so on and so forth. But it never ends, and it gets harder and harder as you get sicker. The chronic illness moves through phases, and these phases are acute, comeback, stable, unstable, deterioration, and dying. And that the work of the illness is different in the different phases. There's three particular kinds of work that Corbin and Strauss identified. And these were illness work, household work, and biographical work, and I'll talk a bit more about each of those in a moment. Chronically ill people have to make a lot of arrangements. So by its nature, chronic illness is disabling. It takes away our functioning, our stamina, and our energy, and so on. So in order to get things done, all the things that need to be done, clinic visits and getting someone to shovel the snow off the driveway or rake the leaves or pick up the groceries or take care of the kids or get a ride to the clinic, chronically ill people have to make arrangements. And these arrangements are constantly falling through and needing to be rearranged, especially as the phase of the illness changes or as the people who we've counted on, they themselves get old or they die or they get sick and so on. So there's this need for continuous rearrangement. I think importantly for healthcare professionals who might be watching this talk, the work of healthcare professionals is only a small part of the overall work that chronically ill people have to do. It's natural for healthcare professionals to think of themselves at the center of the lives of sick people, but they're not. Remember, if we put this videotape on the head of a chronically ill person, most of the time we wouldn't see a healthcare professional in the frame. We would see just the family members, friends, coworkers, and so on. So the work that healthcare professionals do is only a small part of the lives of chronically ill people. And so it needs to fit in to the lives of sick people rather than a sick person having to rearrange their entire life so they can fit the work of the health professional in. Really, if we want to be seriously patient-centered, we have to think about rearranging medicine so that we can accommodate the lives of chronically ill people rather than chronically ill people reorienting their lives to accommodate the needs of medical care. And so this lay work, the work that ordinary people have to do and the work that the health professionals do has to be articulated, it has to be fit together. And finally, there's this concept of trajectory, which I've already spoken about. So the key concept, the most important single concept in the trajectory model, from my point of view, is this idea of what they call the BBC chain. It's their definition of health. So the trajectory model doesn't define health in a standard biomedical way. A biomedical definition of health might be something like the absence of any measurable sign of disease or infirmity, or the measurable deviation from normal parameters of blood pressure or temperature or respiration, or weight or something like that. Instead, the trajectory model defines health as a stable alignment of body, biography, and conceptions of self. So this is a critical concept. I want to spend some more time talking about it. Corbin and Strauss call this the BBC chain. BBC just stands for body, biography, and conceptions of self. So I want to talk about what this means. What they mean is that they're asking themselves, when does a chronically sick person have the subjective sense that they're well, that they're healthy? And their answer is only when these three things hang together in a coherent and self-reinforcing whole. So I want to talk about each of these in turn. Biography is the story of our lives, right? It's the narrative that stitches our life together, that starts with our birth and ends with our death, and in the middle is all of our triumphs and tragedies. But it's the narrative that gives our life coherence. Conceptions of self are our identity, our self-concept, this idea of who we are. If we think of a novel, right, the biography is the narrative that stitches together the entire story. Conceptions of self is the identity of the main character. In this case, it's the sick person, him or herself. And finally, there's our body. So a biomedical conception of illness focuses really only on the body and not much else. So what Corbin and Strauss do for us is introduce biography and conceptions of self as critical components in our subjective sense of well-being. So they say we are healthy only when our body functions well enough to let us engage in performances that allow us to do the things that let us be the person that we are, that allow us to live out the narrative that's articulated in our biography. So depending on what sort of person you are, this can mean different things. But, if you're an athlete, you have to have a body that's strong enough and flexible enough and nimble enough so that you can run or jump or throw or catch or skate or shoot or whatever it is that you do. So your body has to have that capability. That allows you to fulfill your conception of yourself as an athlete, to engage in the performances which allow you to fulfill that aspect of that vision of your identity. And as you do that, you're able to act out the stages that are articulated in your biography. When all these three things hang together, we feel a subjective sense of well-being. When they don't, we don't. When any of these things breaks down, any of these linkages breaks down, we feel unwell. The problem is that this BBC chain, this connection between body, biography, and conceptions of self, is inherently unstable. It's wanting to fall apart all the time. So entropy is such that, disorder increases. So this applies to the BBC chain too. So left alone, this connection between body, biography, and conceptions of self tends to fall apart. It takes work to keep it together. And I always have had this metaphor. I got this metaphor off this image off of Wikipedia. This woman balancing plates on sticks. And the only way you can balance these plates on a stick, if you've ever tried to do it, is to keep spinning them. It's only by spinning them that they'll stay balanced. The moment you stop spinning them, they fall down. So this is the metaphor I have for chronically sick people, is that they're trying constantly keep all these plates spinning. And the moment they stop, something falls apart and their sense of well-being falls apart. Their body may fail them. Some arrangement may fail them. But they can't keep the linkage between body, biography, and identity together, and they suffer because these linkages are broken. So the BBC chain, this connection between body, biography, and identity, can be destabilized by disruption in any of these elements. Disruption in the body, that's what we normally think of when we think about illness. We think about the body failing us. But disruptions in biography can make us feel unwell, and disruptions in identity can make us feel unwell. So I'm going to give examples of each of these to help you think about what I'm trying to explain. So first are disruptions in biography, something like unemployment, divorce, the death of a child, or failure in school. These are upheavals and disruptions in our lives that are very dramatic. And it's quite well known that these kinds of upheavals, these disruptions in the story of our lives, actually make us sick. There's very good evidence that people who become unemployed or divorced or lose a child or fail in school, if you follow them for the months and years afterwards, it's quite common for them to get sick. And people who have just been divorced in the next year get sick more frequently than people who haven't been divorced in that prior year, and so on. So here I have a series of postcards from Post Secret, which I use by permission. I appreciate Frank Warren's giving me permission to use these in this talk. So in this postcard it says, "This is not the life I signed up for." I think this is what it feels like when we experience a biographical disruption. You know, the life we signed up for is the one where we're sort of happy and healthy and things go along as planned. But life isn't always like that. And for those of you who may not know what postsecret.com is, it's a community art project where people send in handmade postcards with their secrets on them, and they're curated and posted on the web by Frank Warren at postsecret.com. So I'll show a series of these. So there are disruptions in conceptions of self also. One of these might be coming out as gay, or discovering that one is adopted, or committing immoral acts. Any of these things can disrupt our sense of ourselves. That is, we have a sense of ourselves as not adopted. We think we're the biological child of our parents, and one day they tell us we're adopted. This creates enormous disruption in our sense of ourselves. Or we had, part of our identity was that we were heterosexual, and then we come out as homosexual. Or that we had a conception of ourselves as moral beings, and then we commit an immoral act. And this disrupts our sense of ourselves in a way that can disturb the BBC chain and make us feel subjectively unwell. And finally, of course, there are disruptions in the body, or what Corbin and Strauss call body failure. So body failure, our bodies can fail us in too many ways, unfortunately. When I was preparing this slide, all I did was open up a book about side effects of drugs. And on the first page, I think I found all of these side effects. So paralysis, tremors, limps, memory loss, incontinence, fatigue, constipation, and so on and so forth. Our body can fail us in all these different ways. And it does as we grow older and as we get chronically sick. So obviously, body failure can disrupt the BBC chain, this connection between body, biography, and conceptions of self. And it does so by interfering with our performances. So it isn't just body failure, body failure alone, which disrupts this connection between body, biography, and identity. There's sort of a process that mediates that, which I want to explain. So illness manifests itself in our lives. So we become aware of an illness as a body failure that destabilizes the BBC chain. So sometimes we have body failures which don't destabilize this connection between body, biography, and conceptions of self. And those body failures we ignore. We can ignore them for months, years. There's a big literature in medicine about illness delay, about people waiting a very long time to have a symptom checked out by a doctor. And that's because if the symptom doesn't disturb the BBC chain, if it doesn't disturb the connection between body, biography, and identity, we don't feel unwell, and we're able to live with that symptom a long time, even if biomedically it might seem like we should have had it looked at long before. So it's only when body failures disrupt this connection between body, biography, and identity that we begin to attend to them. So the primary motivation of a chronically ill person is to restore or maintain the alignment of the BBC chain. We want to keep this linkage together. That's what makes us feel like substantial human beings, integrated, and so on. We have all these colloquial expressions like, I'm falling apart, or I can't keep body and soul together, or it's all falling apart. Well, what's all falling apart? And I think, well, it's the BBC chain that's falling apart. We can't keep body, biography, and identity hanging together in this coherent way, which allows us to feel healthy and whole. So when people get sick, their primary motivation isn't to restore their blood pressure to a normal range or their blood sugar to a normal range. They're not very motivated to do that at all, normally. Some people might be a little bit. But the primary motivation is to pull body, biography, and identity back into alignment so that we can have that subjective sense of well-being. How? By any means necessary, as Malcolm X says. People will restore the coherence of the BBC chain by any means necessary, which means if what doctors and pharmacists and nurses are recommending helps, they'll do it. If it doesn't, they won't. They will improvise on a daily basis anything they need to. And I say they, I mean we, when we get chronically sick, will improvise and will self-regulate. By any means necessary, we will restore the coherence of this link between body, biography, and identity. So I have a simple theory of adherence or self-regulation. It's one sentence. If a regimen helps to stabilize the BBC chain, people will follow it. If not, then they won't. I don't think it's any more complicated than that. So, to summarize part one, a lot of people don't follow the advice that they get from healthcare professionals. We're not exactly sure why. Being patient-centered might help because this medical-centered view, these 74,000 articles haven't solved the problem for us. The trajectory model from Corbin and Strauss and Kathy Charmaz and others gives us an authentic patient-centered account of chronic illness, one which is based on interviews with patients themselves or people who are chronically sick themselves. And finally, chronically sick people are motivated by the desire to keep body, biography, and identity in a coherent alignment. So I'll continue talking more about this in part 2. Thank you.